they want to see how I do the shots. So what's nice about the camera here is that we can put our patients into it and then change this. This is engineered to do anything your arm does. Turn it upside down, so if you're doing a wrist, you're doing a hand, you can easily place it on there. When you get into smaller joints don't need to be injected. So when you do inject them, whether you're doing thumbs, which is the most common area of arthritis in the body, it hurts. And basically, I know, and basically tell your people, okay, look, this is going to hurt you. Okay, I don't want to do it, but this is going to hurt you, okay, but you're going to be better. Okay, so they will bear with it. You know, you have to be honest with people. You just can't go ahead and stick them, because they're going to hate you for it.
And ice 4 times a day, right?
Ice is your friend. I want ice before any other therapy, okay? So ice, 20 minutes, 4 times a day. You have to watch your skin, not directly on your skin, because you can get thermal burns very simply.
A towel, put a towel down.
Put a towel down first, okay?
Can I move my arm at all or do anything in that?
Can you move your arm at all?
3 days?
Yes.
Should I exercise it at all?
If you are going to go to the gym and lift weights, I would say no. Okay? But if you're going to, you know, just do some ranges of motion like that, that's perfectly fine with me.
I just like to put my bra on.
You can wear your bra.
Come
on, let's go. Come on.
Right here? It's too painful?
No.
Tell me where. Keep your arm down.
Here, right there. Start there, and it's going to have to come all the way out to here. So big circle. I'm a big one on betadine and then alcohol. And knock on wood, I haven't had any infection.
I can take this off.
No.
Fine.
Leave it down like you had it.
Just stay still.
Go from the medial to the lateral.
More wider. Is that good enough, or you want more?
Give me another.
Get it like this.
Start here and then go out. Gently, that's it. Mm-hmm.
Is that lidocaine?
You'll get lidocaine. Mm-hmm.
Wait a minute, I'm going to alcohol.
No, get alcohol on there now. Okay? That's good.
All clean.
All clean. You keep moving, I'm going to get you. I see you moved and changed my whole everything. There you go, just like that.
Super still.
Okay.
Perfect picture.
Okay, you want to get the ethyl chloride spray? Okay, I'm going to do the bicipital tendon first. Good. This is just, now I want you a little bit of fluoro for me.
Breathe slowly in your nose, out of your mouth. Slow, slow, slow. Slow, just concentrate on your breathing. In your nose, out of your mouth. Slowly.
Okay.
Almost done, almost done. Breathe really slow.
This will burn. This is the lido.
Just concentrate on breathing. It'll help you. In your nose, out of your mouth.
Okay. That's lido.
What was the first thing you did?
Lido. I had it in 2 syringes. Okay, now this is PRP.
You're not doing any
Wolf fluoro.
fluoro?
Yeah. You really, on a tendon, I don't know that you have to fluoro on a tendon.
Okay, I got you.
If I had ultrasound, we could do that. Now, this will burn. You're going to feel a burning sensation.
In your nose, out your mouth.
There you
Slow,
go.
help you.
Okay, you got a 4x4 or something? And that's just the tendon now. I have another injection. Now I'm going to go posteriorly. I'm going to use a little bit of Lido. A little pinch and a little burny sensation.
Slowly.
Good.
Doing really, really well. Almost done.
Now another stick.
Breathe, breathe. Slowly, almost done.
There we go. Now fluoro for me. Hit that.
What's that?
Hit the red thing.
Once?
There we go. See, I'm right inside the capsule, right inside now.
Out of the way?
What I'm going to do is I'm going to leave that needle in. That's perfect. And basically do my PRP. Slowly.
Breathe.
This actually, people feel pressure when you do this.
It's almost done.
That's it. And voila, done. Simple.
Wasn't bad. He was very good.
You were very good.
A good patient. Questions? It's pretty simple procedure that we all should be doing.
Dr. McGrath,
Yes.
what determines your positioning for your anterior approach on the shoulder? Is it specifically what you see on the fluoroscopy? Okay.
And
All right,
I-
so
Landmark-wise, what do you use?
Well, basically the coracoid process, okay, and then I feel back here for the acromion. So when you put your fingers like this, okay, that's basically the position of your needle.
Gotcha.
Okay, so you just slip inside of the coracoid process, and you're going right back and going toward the acromion. So that's why I had my hands back like
So
this.
it's actually the opposite of the way we learn posterior.
Exactly.
Because we used to use coracoid process as your anterior landmark, and then you line it up right behind it. 2 steps out, 2 steps down. That's your landmark.
You can see how easy this was. This is so easy, and it's
Just inside the coracoid process, that's your actual landmark.
Now I noticed when she did a knee, she left the needle in there and unscrewed it and did all using the same needle. You did 3 steps.
well. I was doing multiple sticks. So she had two specific problems, and that's the reason why. But normally you can just use lidocaine, okay? And then if you want to, you don't need with this to use any sort of dye, but we did, and I did that basically to please the crowd, okay? But then you leave that needle in there, take it out, and put your PRP,
Okay, I didn't see that.
okay?
Okay, so you left it in there. And
Now, if you're doing hyaluronic or whatever, you're doing the same procedure as you would with the knee or anything else, hips.
So you did the back too?
Yep, this is in there.
You went in on the shoulder over here, and it went through the back?
Right here, look. This needle went right in.
Wow.
Okay?
Yeah. I don't feel anything now.
There we go.
Will the lidocaine,
Lidocaine will work for a little bit, and later on today, it's going to start to bother you. You're going to feel a little stiffness and pain.
I'll put ice on it.
Ice it.
I have a big, long ice thing. I'll put a part back here and part here.
Perfect.
You know, should I drape it over this part too?
You don't need it there. You need it over the shoulder.
Just the shoulder.
Yep.
Okay.
Okay?
all right,
Thank you so much.
You're very welcome. Thank you. You're a
couple
great
quick
patient.
things I want to cover before I introduce our next presenter. So when I was floating in the back of the room, I heard a couple of questions, so I just wanted to address those before we move on. The first one was, why isn't he using fluoro? And that's when he was doing the tendon. So when we're doing tendon injections, obviously it's a soft tissue. We can use the fluoroscope to judge how close we are to a specific landmark, like a bone. to give us a better estimation of if we're near that tendon, where that tendon should physiologically be. But when you're doing soft tissue work, obviously ultrasound is going to be a more indicated imaging modality for soft tissue work. So in our clinic, we have an ultrasound cart, a mini C-arm, and a major C-arm, so that we can do soft tissue work, extremities, and spine work all in the same facility. So you do have to dig into a couple of different imaging modalities if you want to do everything. And one thing that's in development, we do a lot of work with OrthoScan, the company that manufactures this device over here, and we're in the process of having them add an ultrasound wand to it. So we're going to be able to get digital X-ray, fluoroscopy, and DUS all on the same platform for about $75,000, $80,000. I don't know exactly what the price will be once they add the ultrasound, but the ultrasound is going to be somewhere in the ballpark of a $10,000 upgrade to it. So that'll all be available on the portable platform. They're also going to use a larger battery pack, so you can run it for up to 4 hours away from an electrical outlet, which will be pretty cool as well, especially when we start doing more mobile. The next question I heard in the back was about the contrast dye. So at the very end, he used the contrast dye to confirm that he was intracapsular. So anytime we're doing an intra-articular injection, we're going to use contrast to confirm needle placement. Anytime we're doing muscular or tendon or soft tissue, it's not necessary. Any other questions that I can address before I introduce Dr. Huey? And then when Dr. Huey starts presenting our stem cell and PRP workshop presentation that we do to our patients to have them come in and start care with us, I do want to try and still do some live procedures off here to the side. So I'll bring Stephanie up real quick to introduce the next patients that are going to be over here. And Sarah Liebling and I will be over here supervising procedures quietly while Dr. Huey is speaking, as to not draw too much attention away from him. Any other questions so far?
Show everyone this. This is my Bible.
Ah.
That teaches them to do any soft tissue or joint.
You tell them.
For those of you who haven't heard already, this is my Bible. This will tell you and teach you how to do any soft tissue or joint injection. Gives you all the landmarks, tells you how to do it, okay, basically gives you the equipment that need to be done and the M codes for it. So every one of our practices should have this in there as a reference guide.
So it's Amazon, and the hard copy I think is $180, but if you have a Kindle or an iPad, you can download a digital version. I think it's $55, and it comes with a link to videos. So some of the videos we're actually going to show you in some of the presentations later came from this. It's a practical guide to joint and soft tissue injections, 3rd edition, by James W. McNabb, and it does include the interactive ebook with videos. Really, really good one.